It's my honor to have all of you today this panel discussion on COVID-19. The COVID-19, a global health pandemic, is rapidly changing the ways we live and work. Hospitals around the world becoming overcrowded with the patients due to coronavirus. The healthcare workers, mainly nursing and medical maternity, frontline of the pandemic is working tirelessly in the battle against COVID. Will you all agree with me? Even Second World War, nurses plays a major role, a vital role to treat the soldiers, army people like a warriors. So while performing their duties, doctors and nurses have lost their life, as well as many people were exposed and affected to COVID-19 positive cases. At this time, I would like to take the moment to offer a silent prayer for those who are affected and exposed their families to the same. A prayer can heal many things. Asking God for guidance and protection while we are at work, keep us safe and our families to be safe. With this note, we will start a session without wasting much time. In response to the pandemic, a Medicover hospitals will host a symposium on nurses versus COVID-19, a global overview. My name is Swati, working as a nursing head at Medicover hospitals. Today, I would like to introduce eminent speakers. It's my pleasure. Really, I work with some of the speakers in this group. I'm really glad to work with those people, and I have learned a lot of short notes with them. And there are international speakers with us. First, I would like to introduce Dr. Padmavati Ramaswamy, Assistant Professor in Clinical Nursing, Cizik School of Nursing, University of Texas, Health Science Center in Houston, Texas, from USA. Welcome you, ma'am.
Thank you.
Mr. Suresh Pakiyam, General Manager, Haywood Hospital, Staffordshire and Stroke Trend Care Group, NHS Trust from UK, London. Welcome you, Suresh.
Thank you, Swati, and thank you, everyone.
Miss Campbell Lorraine, Senior Staff Nurse, Royal Brompton University from UK, London. I welcome you, Miss Lorraine. Miss Tankam Gomez, ma'am is President of Clinical Health Services and Arhon Healthcare Center and President of Association of Nurse Executives in India. Ma'am has done tremendous work for ANEA Federation, which I have seen every day, day in, day out, lot of messages in ANEA group and lot of support from ANEA group. We welcome you, ma'am, Ms. Tankam, ma'am.
Thank you.
Dr. Jyoti Clara Michael, Vice President in ANEA, member in ANEA, and ma'am also very strong support pillar for the nursing. And she is Director of Nursing, Strategy and Planning, India Operations Division, Parkway Pentai Limited. Ma'am, we welcome you from Medicover Hospital.
Thanks, Swati.
Miss Jocelyn Cyril, she is one of my guru. I work with her very close associate 3 years in Continental Hospital. Ma'am works in Atmos Hospital in Gurgaon, Haryana from Delhi, from India. We welcome you from Medicover Hospitals. Josephine, ma'am. I would like to welcome, last but not least, Captain Sunita Fernandez, Deputy Director Nursing Director, Ruby Hall Clinic, Pune, Maharashtra from India. I welcome you, Sunita ma'am.
Hi, namaste.
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 First, we will go for directly into the panel discussion. I would like to ask a question, Dr. Padmavati Ramaswamy ma'am. Ma'am, there are situations where we have where knowledge is lacking in healthcare systems. Many of nurses, either all other paramedicals, knowledge is something where we are lacking. And when there is a pandemic comes, there is a health threat. What does nurses plays a major role? Do's and don'ts. And does it make a difference when the nurse is posted should have knowledge? What is your opinions and thoughts? Please share with us, ma'am. Over to you, Dr. Padmavati, ma'am.
Sure. I got. So yes, nurses play a very, very important role in healthcare of patients with COVID-19. We nurses are an integral part not only in safe patient care, but also we are also patient safety advocates. So a well-informed nurse is a better prepared nurse. So education of the nurses is really, really important in order to provide adequate care. Also, we in healthcare, in hospitals, in a healthcare institution, should empower the nurses in order to be better informed. So, as healthcare institutions, a big responsibility is to educate nurses in the following areas. I think we have to educate the nurses in preparedness. As you know, I think globally we are not prepared for a pandemic. We are all learning on the go. So definitely, but nurses being the frontline staff, we have to prepare them in educate them in preparedness, early identification, and notification. Also in isolation, quarantine, monitoring and hospitalization guidelines, and also educate patients in order to minimize the spread within the community. So some of the areas that we should, for example, like I was talking about preparedness, we have to make sure that they are prepared in screening and isolation procedures, and also provide training and guidelines on the use of personal protective equipment, including the use of N95 respirators, gloves, gowns, masks, eye protection, and face shield, to make them aware, make nurses aware of the updated guidelines. For example, in the United States of America, we use the guidelines stated by the Centers for Disease Control and Prevention, or CDC, which issues daily guidance, and there have been some miscommunication, but it's important as healthcare institutions that we um, follow the guidelines. So in the United States of America, at least, all the institutions are following the guidelines put out by CDC. So they are able to be consistent with what they're doing. Um, Also, I think we also have to prepare the nurses in order to protect themselves. We are seeing every day, we hear news about healthcare providers getting sick because some of the guidelines are not clear. So it's very important for the nurses to be prepared, to be educated in this, in all of these areas as far as pandemic is concerned.
Yes, ma'am.
Thank you.
Thank you. Now, I would like to pose a question to Miss Josephine, ma'am. Ma'am, this question is for you. Josephine, ma'am. Okay. Next, I'll go to Jyoti, ma'am. Ma'am, will you able to hear me? Ma'am, as per Health Advisory Board, you have clear demarcation of between receiving COVID patients, like startup, like how, what kind of setup you have created care for these COVID-19 patients, and what kind of demarcation between OPDs, wards, and ICU setups and isolation units. How is the staff deployment managed for these COVID and non-COVID areas? And with all the fear involved among our healthcare staff in handling COVID patients, what kind of challenges you are facing? How you are managing for deployment of nursing staff? Over to you, ma'am.
So, in terms of the entire plan, preparedness, one thing is infrastructure, second one is the manpower, third one is other resources to support them. When it comes to COVID management, the entire hospital is divided into two. The entire route is like the normal patients. This was in the beginning when we thought that, okay, COVID is not related to aerosol. And we just said that it was droplet, and we had divided the hospital into two rings. Like patients go through suspect COVID into the COVID unit, and then the patient is positive, they are taken care, and then they are moving out once they are fine. The other patients moves into another ring where they go into an ER where the other COVID patients or suspect patients won't come, and then they move out. So this kind of two division in the hospital is happening. All these days we were functioning as one single hospital infrastructure. Now it is divided into two parts. One is the COVID, the other one is the non-COVID area. Now the staffs were divided into two parts. The regular staffs taking care of patients continue to work, whereas the COVID staffs were identified based on their criteria. Those who are healthy, those who are of 50 kg and above, and those who are willing to work, and those who are able to understand the knowledge about COVID, and those who have undergone the privileging of caring for COVID patients. Now we have put them on three different ABC category. So the A category staffs, that is the A block staffs, while they are working. The B category staffs will be resting. The third group of people would be in the non-COVID area. Whereas once that COVID ward staff, the 7 days of exposure is completed, we would rest them. And then the second batch takes over. So why do we do it is just to see that the nurses have enough rest and they are taken care. And on top of it, we are also providing them a lot of support in terms of daily monitoring and nutritional support and other facilities where they are screened to see that whether they are getting exposed. And on top of it, like the other speaker told, PPE privileging and enough PPE is given, doffing, buddy assessor to see whether whatever is being taught and put in the hospital policy is being adhered. Due to anxiety or due to some disturbance within them, if they do not follow, then the buddy observer steps in and supports. And by chance, if the PPE gets on, or probably it is being doffed, or maybe it is displayed elsewhere in the body, so immediately the buddy comes in and then doffs it and ensures that the particular staff is supported. And also when they are out, that is the 7 days of break or 14 days of break which they have, we are also taking care of them by providing enough recreation and support and nutrition, and also prepare them by counseling, because psychological support is very, very important. They are away from home, they are away from loved ones, and they depend on us as the clinical leaders who are supporting them. And leaders in the front, we are in the front.
Group nursing head for Fortis in 2012, and I have been totally involved in training, education, mentoring, coaching, etc., etc., etc. And now I'm an entrepreneur also, but I'm very, very close to nursing because that's my passion. So that's why I'm also the president of Association of Nurse Executives India. Now, what makes me eligible to answer that question? Eligibility, I would say, is probably I had been right from the very beginning. I have been involved with government bodies, of course, the nursing bodies, trying to understand that how best can we support in this pandemic, where this has hit us, from nowhere. So all of us learned the terms epidemic and pandemic and all this stuff, and I don't think that anyone who is alive today, I mean, at least practicing or, learning, any one of us have ever, confronted a situation like this, a pandemic, none of us. So it was a very new entity and everybody was trying to, understand. So now from the word go, from very early March itself, we were involved. So I would endorse whatever Dr. Padma had mentioned, Jyoti had mentioned, this is a time where we all are learning together, and we also look up at CDC guidelines, and it had been like that for I don't know, time immemorial, and because that's one body that everybody refers to. And yes, there had been very good NHS guidelines also. There are two. NICE is another site that I used to go, and then CDC is another site that I used to go to refer when we are developing contents. Now coming back to our country, in India, the guidelines have been formed under Ministry of Health India, which is based on WHO and CDC guidelines. This is what so far had been the case. And the Indian government has been very, very prompt in coming out with all kinds of guidelines that is required to handle this pandemic. Timely, they have released all that guidelines. And when it comes to training, I think the training is too much. and everybody is coming up with training modules. We have online, we have offline. Every hospital is having their own training, and Jyoti already mentioned, Dr. Padma already mentioned what are the key areas of training focus. So now being everywhere, and I get a lot of phone calls from staff nurses, from leaders, from private and public. I am private a lot of things which are not right in what we are doing. So considering all that, I would summarize to say, do the training, very good. Do it again and again and again. But my one humble submission will be, please go and check. How is it that they're doing it? Please don't be, rest assured that, I have given X hours of training, or I have covered 100% of my nurses. I think the question is, if you look at the outcome based, what will be the question? You have everything in the world. The PP is there. The training is done. Then if outcome says that the nurses are getting infected, doctors are getting infected, then there is a question to be asked. If the PPs are well in number, there are two situations when this transmission can happen. One, that you don't have the right PPE for the right things. Number two, you have everything. So either you have not, specified what to be used when, so you overused it. Now you don't have the right PPE for the right exposure. So I would summarize to say that all the trainings should result in outcome. It's very important to watch that how our nurses are doing. So when you actually deep dive into the training, you will find that we are not doing anything more than standard precautions and hand hygiene, which has been there from time immemorial. I mean, from the time the word go nursing, I learned hand hygiene, standard precautions. And why were we having struggle? Because it's like, oh, it will happen to somebody else, not me. I had respiratory isolation patients. I had problem with my nurses who will not adhere to the guidelines. So now what is happening? The fear of death is hanging right in front of us. So everybody has become over conscious of hand hygiene and standard precautions. So everybody is looking for the right PPE. We want that. So I see a little bit of silver lining in this pandemic is that suddenly the world has woken up to hand hygiene. Everyone knows hand hygiene, hand steps. So coming back to healthcare, my submission is only that after training, please go and check what exactly is happening on ground. Are they following? And if one break happens, go back and check that despite the PPE, why did the person get the exposure? Did they break? So I was talking to one CEO today morning, and I'm very happy to note that when I was discussing, don't you think that any hospital, if there is a positive staff case, there is a need to do RCA to find out? So everybody says I've done everything, and suddenly one day, one doctor, one nurse gets positive. Then the question says, "Ki, what are you, talking about? What were you doing?" So these questions will come. So there, the CEO mentioned, I watch my COVID areas, where the PP is being done on my CCTV. So, I must, I thought I should not take the name, but let me tell, it is from Jyoti's group, Dr. Vivek Tollalikar in Mumbai, and he's handling lot of COVID positive patient, and he's an old friend of mine. So I do pick up phone for some help. So I think lot of things will come into place apart from training, engineering control, administrative controls. Everything has to converge to one place for the outcome that we need. So that's how I will summarize the training piece of everything. And I'm very sure nobody here or anyone right now, everyone knows across the world that what are the topics that needs to be trained. There should be buddy, everything is there. I think the acid test is execution. With that, I will stop my comments. Thanks, Swati. Swati, unmute yourself.
I completely agree with you, ma'am. The keynote message which I have learned from you, the supervision and execution plays a major role. Once you train one hour classroom and you make sure that everybody has know the video of without having hands-on training how to wear PPE, donning, doffing techniques, and then how to do hand wash techniques. When we presented before this pandemic, When you see our infection control team, whenever they present hand wash complaints, majority of hand wash complaints will be either 65 or 70%. Now, when pandemic breakdown comes, the hand wash rates has gone high. And everybody is now, they sensitized how to do hand wash, what kind of hand wash, when to do, what to do, irrespective of any healthcare worker, even a fourth class employee, he know the importance of hand wash. That become, today's, the pandemic has made to realize our life. So thank you very much, ma'am. It's valid point. Next question to Mr. Suresh. Suresh.
Yeah, I can hear you, Swati. Yeah.
Yeah, there are many challenges.
Yeah.
Okay, tell me in your UK how you are practicing during these challenges as a nurses. You may finding difficulty to maintain your mental health and well-being. When coping up with so much uncertainty, all fear is involved. The nurses are fear to take cases, and even though, however, we do train as a mentorship or buddyship, whatever you call it, however, we be as a leaders to support for them, but still the fear is not go away from them. So fear factor from the parents, they have a pressure. No, I will not receive, ma'am. Please don't ask me to go and work in COVID. Such kind of fear is there within their mind. So how you involved to take away that fear among healthcare workers or staff nurses? How we are dealing breaking bad news, especially in India, breaking bad news only doctors does. Either incentivist, either consultant, either whoever the primary consultant deal with the patient family, he will execute the information to breaking bad news. As a nurses, we haven't practiced because we are not nurse practitioners. Nurses are even to take decision making in critical situations, but breaking bad news is not their cup of tea. How you are practicing in UK such kind of COVID patients? There are very well versed nurse practitioners are there in UK. How you handle the breaking bad news and how you train your RNs and how you empower them? Can you brief about that?
Okay. Thanks for the question. It's rightly pitched. I think everyone agrees that sometimes we over focus on physical health. Often we forget about the mental health. I think it's ever so important, isn't it, at this time, especially the crisis time when the pandemic is happening. So yes, we have to understand it's very unsettling and sometimes scary. I scare myself, and every day I go to work and I always feel that, oh my God, what's going to happen today? How many of them are going to be sick? How many death report is going to be reported to on my desk? So it's very scary, really, isn't it? And also, often we believe what comes on WhatsApp more than what's actually there in the facts. Do we follow the legitimate resource? Do we follow the legitimate guidelines? That's very important, isn't it? So yes, and also we have to be careful what we pitched ourselves. As a medical professional, we always say that we built on resilience, don't we? The only reason is we often want to carry the DNA of Mother Teresa and Florence Nightingale. There's nothing wrong with that. But often we forget to think we're all built on emotions, don't we? We have our families, we have our children's. So that's why we become emotions. So emotional well-being is very, very important and key part of our staying healthy, staying well, continue to work, continue to care for our patients. That's why it's very important. So how do we do that? Often we often say we are caring for others, compassionate, and want to do the right thing for the patient. But how often do we look after ourselves? How often we ask ourselves, am I okay? Yeah, that's why we need to keep asking ourselves, am I okay? Do I need help? Do I need to seek help? That's very important. So it's okay to say that I'm not okay. So we need to have that practice every day. We have to have that. And also be kind to each other. So there is no hierarchy at the moment. There is no clinical directors, medical directors, nursing superintendents. Yes, there is a staff nurse, healthcare assistant. No, break the barriers. Be kind to each other. Say thank you. It doesn't cost a penny, does it? We are not asking for mega bucks. We're not asking for a pay rise or anything, but say thank you every day. That brings the energy to a lot of people. I think they'll go extra mile just by saying thank you. So that's very important. So I'm going to pitch two things really. One thing about the self-help, yeah. Another one is helping others. So let's look at the self-help. Self-help, yeah. There's a number of resources available. But we need to look where it is really. The WHO has produced clear guidelines on mental health and psychosocial consideration. So please look on those and follow that instruction, follow the guidelines. That's very important. And also in UK, we got a Mind Charity. They produced a document and guidelines specifically how to keep your mental health well-being during the outbreak. I think I will send all the links to you as well. Please share it with all our staff members. That's very important. And also, let us not forget about keeping our routines. It's not just about going to work, come back tired, and go to sleep. Follow the routine. Simple exercise, yoga, watch some good videos, maybe watch some fun films. Yeah. So, and also, don't forget that when we are in a self-isolation, spend more time with our family. We often forget that. We often communicate through phones, don't we? Well, I'm not sure that is a good news for everyone. We all want to spend more time with family. So, but yes, try it. Yeah, that's important, isn't it? And also stay connected with the virtual platform as well. Use it wisely. Yeah. Keep in contact with your friends. Talk about day-to-day stuff. Not always about the COVID related. Just talk about the fun stuff. Yeah, that's really important, isn't it? And also, let's go to the helping others. Yeah, how do we do that? Within our mental health sector or hospitals, always keep the communication channel open. So people have to feel that even out of hours, after 5 o'clock, okay, all the managers gone home. Nobody's there to support me. Whom am I going to reach out? So make sure there's a communication channel 24/7. Doesn't matter Saturday or Sunday. It's very, very important, guys. So how do we do that then? That means we need to have a coordination team working together. So set up like an incident control team. That's very important. So keep that going. And also be honest with each other, not too honest sometimes, because that may bring anxiety. For example, a typical example would be, as a senior a senior clinician, you may know that the PP is going to run out by tomorrow. Are you going to tell your staff? They'll be panicking. They won't come to work tomorrow, next day. So be careful, yeah? Strategize always, okay? Think about, consult with your senior leaders. Okay, we've only got 1 day supply. What are we going to do? Are we going to coordinate? Are we going to collaborate with other stakeholders? Get some help. And also give a clear guidelines, how much stock take each individual hospital has. Can we share it? So strategize first before you communicate. So don't be too honest as well. So be careful how you communicate with people. That's very important. And also psychosocial factors. Okay, we all have a psychologist, because often the front line psychologists play a vital role, but not at this time, guys, because our nurses and doctors and AHP staffs are working hard, but psychologists actually, they don't have much work, irrespective of what's going on. So they have plenty to offer to the staff in terms of psychological support. So bring them on board. So say, set up a team of people with psychologists, provide them the debrief and the daily updates to people, and also create a line as well, probably a reach out line for all the staff. If they want to pick up the line, straight away ring them. Guys, I've seen a patient dying in front of me today, or I had 10 COVID patients. I'm really melting down. I'm crying today. Can you help me? A 5-minute chat. That's very important. I think that's important. And also peer support as well. Huddles. Yeah. Unfortunately, we can't huddle now. We can't hug like before, but let's do virtual huddle. or, or, or stay apart 2 meters away and just say that we are actually having a huddle, guys. Yeah. So that's very important. Keep that going. And most important thing people are worried about is the availability of PPE, isn't it? Is worrying. If I want to go to work, if I want to look after COVID patient, you're not asking me to go to the battle, go to the war without a weapon. So that's going to be really dangerous. That means making sure all the leaders that you have enough PPE, provide the right PPE to the staff. That will assure them. They will come to work every day. They will do the job for you. That's very important. And one last thing, because it's considering the time limitation, is very important. The mantra is, when you're dealing with pandemic, we are running a marathon. We are not running a sprint. So how you look after yourself, how you're keeping motivated, how are you energized. Plan it. Suck energy from your peers, suck energy from public. Why do we clap on every Thursday on UK? It's about getting the energy from public, isn't it? So these are all important stuff. And at the end of the day, don't forget that we're all running a marathon, working together. The victory is ours. So there is a light at the end of the tunnel. So we have to believe in that. That's the only way to keep motivate our mental health well-being, Swati. And in terms of asking the question, how do we break bad news to the people? Oh my God, I don't want to be broken that bad news. I don't want to be in that situation, or I don't want to be that clinician who want to break the news. But unfortunately, we are all going to do that. Our staff nurses, doctors will have to do that. In UK, how do we do that? Is we have set up a palliative coordination team. So that means every hospital, every community settings, we have a palliative coordination team. Is consists of all the experts, doctors, trained psychologists, and nurses who are experienced in providing end-of-life care. So they are the people, are the team of people supporting each other. So yes, there is a number of deaths increased, thousands and thousands are coming through, but our undertakers are doing a fantastic job keeping them, providing the respect to the dead people, and also keep the families occupied. But breaking the bad news is very difficult. So we train the staff, provide the resource in terms of palliative care, and also be compassionate. There's nothing wrong in crying with the family. Okay, that's very important. So just cry with the family if you want to, because you build emotions, don't you? Because you look after those patients for a very long time. When they die, you do try to cry. So it's okay to cry, but it's the palliative care team is the important part of the role, really. So that's important. Is there anything else I missed, Swati?
No, Suresh, very well said. Everything covered.
Okay, thank you so much. Yeah.
Now I would like to ask Sunita ma'am. Time is running short, ma'am. Don't take much time. So during the challenges, we have everyone knows the universal fact now shortfall of PPEs. Everybody agree with me. It is not only in India, throughout the world we have these PPE shortfalls. How can healthcare facilities to manage personal protective equipment supplies during the COVID-19 pandemic? Will you able to get supply chain management support, and do you have any difficulties to provide healthcare facilities these PPEs?
Yes, Swati, thank you very much. Now, taking it from there, from what Suresh said, it's like you're going into the battlefield. You see the fire and you're running into the fire, not thinking about yourself. That is the selflessness you can see in the nursing today. So, lot many nurses. This comes from one of the nurses who did mention that we are all into the battle together, right? So, the use of PP and strategizing is one of the most important things for us leaders. We got to think about how to minimize the PPE and coordinate the supply chain. Okay, then use the PPE appropriately, like Dr. Clara already mentioned about it, the strategies that they're doing in the hospital, which is really very nice. Optimize PPE availability, right? So minimize the need. How do we do that? It's like today we can do a telemedicine, right? For the suspected COVID cases. So you can use some physical barriers in areas like triage areas, registration desks, ED, that's the emergency department, pharmacy window, so that you don't use too much of PPE, right? So you can restrict healthcare workers who are not in direct contact with the patient. Those who are in direct contact, you can ask them to do bundling activities, so that if you're going to do vitals, you can do the medications as well, so that you can restrict yourself getting in contact with the patient, and also restrict visitors. So I also like to mention that the type of PP is very important, and the type of people that are, or the personnel that are in that activity. So it is demarcated. I'm sure everybody knows the guidelines and are demarcated with each and every department, and whether it's aerosol or, like ma'am already said, the different kind of PPs. So we do get a good supply of PP as and when we have demand. We do an indent, which was done regularly, and our seniors, they monitor the PPE that is used by the staff, and also, like, you coordinate the PPE. You see that there is limited wastage. because we see there's a lot of wastage. Some of them say they're not very comfortable, you cannot breathe, it gets wet very easily, and some people like to stalk the people. If you see, not many people will say, "Ye mera hai, I'll keep it separately." Baki ka, I do not know. So my ward is okay. I'm comfortable in my ward. What about the others? Okay, so we're not thinking about the others. We say that we've selected this PPE. This is for my department. I face the patients, screening patients at the screening desk. Sorry, staff at the screening desk. Then the ED, the emergency department, the ICUs, those coming in direct contact with the patient. So it is not only for them. We have to monitor that even the other staff. And I always tell my staff, the moment you don this uniform, it comes with a lot of risk that are involved, and which we are prepared. Like Dr. Padmavati would agree with me that we have seen so many of our friends in the past, like with tuberculosis, sciatica, these are some of the occupational hazards that we have accepted the moment we have donned this uniform. That does not mean that we don't use the proper PPE, and we have a regular supply chain that is maintained and which is monitored. So I came across this very good burn rate calculator by CDC, which is a very nice guideline which it has been given, which I think every hospital should follow, or every administrator should take this up, nursing administrator, like number of COVID patients, right? So how many PPE boxes did you have at the beginning of your shift, end of your shift? How many between patients? How many did you consume for the day? How many in a week? What is left with you? What is the average consumption? What is left in the boxes at the end of the day? What is the burn rate? So where are we burning? Are we burning? Or we got to look into where we can improvise, where we can, keep those staff which are on duty, like ma'am said, Dr. Clara said as well, that they are kept on duty with the same PPE which you provide. You see that they are not getting sick. You monitor them. You monitor their health as well, and then you do an average consumption. So when you see that average consumption of PPE in the boxes that are there, and what we got to do for the next day maybe, or the next week, and how we inform or educate our staff what you got to do with the PPE that is available. How do you use your PPE, and what are the ways and means that you can restrict yourself, that you do not use the PPE which is if it is getting wet. So you have a buffer system as well. So you keep a buffer with you, so that sometimes it does happen, and then we also restrict our visitors. So we do not have visitors coming in, and we control this. So that's how you can keep the supply chain, because now we are having a lot of problems, in supplying PPE and getting the PPE also, especially in India. It's really very tough to get the PPE at the right time. So we have to keep our buffer, we have to keep our backup, and we also got to see how we can decrease the burn rate and how the supply chain is maintained, right? Thank you, Swati. So this is all that I have to say regarding the PPE and the supply chain. We can't hear you, Swati.
It's a very valid point, ma'am. I agree completely with you. And we also having same supply chain system, having buffer stock, and we are maintaining with the supply chain managers to get buffer stocks. And we have all kind of facilities in our hospital also, ma'am. Ma'am, these questions even to Josephine, ma'am. Josephine, ma'am, will you be able to hear me? Yeah, ma'am. How about your hospital? Ma'am, your mic is mute.
No, you can't hear me?
Yes, ma'am. Yes, ma'am.
You can hear now?
Yes, ma'am. How about your hospital, ma'am? Like what kind of PPEs you're providing? How can healthcare facilities, like do you have supplies for COVID-19 patients, enough stock? Do you have any challenges? Can you give your sense of your...
So I'm sorry, due to network connection, I couldn't join you from beginning. Let me start the whole process. This whole pandemic that's happening, and suddenly the whole, the entire hospital is into a different activity altogether. It was a great challenge in the beginning. And talking about PPE, let me say our management is kind enough and fast enough to get the right PPE at the right place. So we have COVID unit, we have non-COVID areas, and they could get the PPEs adequate in numbers, good in quality, on time, and the PPEs are in place. And the most important thing is genuine utilization of the PPE, as the previous speaker said. So the nurses and the doctors, the technicians, the general duty assistants, the housekeeping, everybody is trained enough now how to use the PPE, when to use the PPE, the kind of PPE to be used. I think we have done enough training and that is happening successfully. Then comes the training on biomedical drills, how to donning and doping was, I think, given a lot of importance in our training program. Throughout the hospital, we conducted the training so that people who are getting posted to the unit, they are well aware of this. So rightly PPE was used and discarded. So we have no issues. Now coming back to the second point, you told me the challenges. The number one challenge is uncertainty. Now, so far things are looking okay. We have the right staffs, right in number in all the COVID units. And we have batch 1, batch 2, batch 3, and we have a batch as backup. And they are all doing 6-hour shift. They are getting adequate rest. Their physical and mental health is taken care. They have enough rest, and their nutritional aspect, psychological aspect, everything is taken care. Their accommodation is good. Everything is good. But the biggest challenge going to be is uncertainty. So, you know, how long it's going to be. And that's what the question comes from the nurses. So we have to keep motivating them, keep energizing them. And I heard one of the speaker telling, be in touch with them. So what we do as, you know, the core team, the nurse leaders, we are always in touch with them. And of course, we cannot meet them every day. So we have created WhatsApp groups. We send them good videos, good movies, good comedy shows, and they watch and they enjoy and they send us good feedback. I think the biggest challenge is keeping their motivational spirit high, their willingness to work in COVID units on a regular basis, their eagerness to learn and upgrade their professional skills, and their passion for continuing to take care of, you know, COVID affected patients, even suspected individuals. It's a long journey going to be, and this uncertainty, they have to learn it, they have to live with it, and they have to face it boldly. So what I tell them, and we all leaders tell them, is be courageous, be fearless, be together, and together as a team, we can overcome this huge pandemic which all of us are facing. Thank you, Swati.
I agree with you, ma'am, completely. The demarcation, either nursing appropriate deployment, if we have not done as a leader, we will be failure everywhere. So we have to do proper deployment, manpower for COVID areas, and supply chain system to coordinate every day, day in, day out with our supervisors, allocating sufficient PPEs to the workplace. And we need to boost our youngsters. Like every day, we need to keep on motivating. We make them, be strong leaders as a. We are there with you, and we will work with you. And we have to create such kind of handhold each other as a leader, and we should become a mentor, and we be as a part of a team leader, and we have to meet every person every day and to make sure that as a leader she comes and she watches us and she'll take care of that kind of handhold we have to give our juniors. It's a valid information, ma'am. Thank you. I'll come back to you, ma'am. Miss Lorraine. Yeah, Miss Lorraine, hi. Yeah, I need to ask something interesting. One question, like what should happen if a nurse or a healthcare worker is exposed to a patient with COVID-19? What measures and what kind of precautionary preventive aspects you have taken? Can you share your ideas with us? What kind of practices you are doing? If any nurse is exposed to the COVID patient, what kind of challenges in UK, like how nurses are, fear factor, and what kind of challenges they are being, what kind of precautionary measures and preventive aspects you have been taking?
I think I'm going to widen the conversation a little bit for you. I think colleagues have very well developed the arguments against PPE and training of staff and staff well-being. What the Brompton has faced is a challenge in quadrupling its adult intensive care beds. So we were asked within a 10-day period to raise our critical care beds from 18 adult beds up to 70. That is a 4-time fold of what we would normally provide. That provided a significant challenge to how we managed those beds, how we educated our staff to cope with looking after level 3 very sick critical care patients, and how we maintain that, because as one of our colleagues has said, this is a marathon, not a sprint. So my colleagues, the other thing about the Brompton is actually we are a national ECMO centre, and we provide normally between 5 and 10 ECMO beds for the UK nationally, and we've been asked to quadruple that facility as well. So in addition to taking nurses who normally work in a ward environment and training them to work in an intensive care in a very short time space, we have been working with our critical care nurses and taking them into doing more highly advanced specialist care for ECMO. And I raise that because is that something of interest to you guys? I have my colleagues beside me who can speak briefly on how we've achieved these things. Interested? I'll turn the camera to Ian, who will give you a very brief update of how we've trained people.
Hi there, my name is Ian. I'm the lecturer practitioner in intensive care nursing. So I work between the University of West London and the Royal Brompton Hospital. But we've, basically to allude on to Lorraine's point, is we've implemented training, both hands-on training and virtual training, particularly around critical care skills and skills on ECMO, but also how to manage that with COVID patients in terms of minimizing risk of exposure and aerosol generating procedures. So we have a few things that we've been doing with that in terms of modifying procedures to reduce the risk of exposure to staff, and educating staff about, as you've already talked about, the correct use of PPE, and also the reassurance of staff that if they are correctly donned properly with the correct PPE which is required for that particular procedure, that they are, as long as they're following those guidelines and checking that we're following those guidelines, that are safe. We've had a lot of experience of buddying very experienced critical care nurses, both with ward staff who then can look after critically ill adults, both on ECMO and off ECMO, so that they have the adequate level of support. And that support goes not just in an educational fashion of telling someone how to do something, but also having peer support there, both within the shift and then after the shift as well. We're currently also developing other staff rest facilities that are improving both their ability to access education outside of a red zone, or we call them red zones or COVID areas, but also their ability to be able to offload at those points as well. I think one of the things that's put us into a really good position is that we have an absolute focus on education all of the time in our unit. And we provide educational courses. So we have a very high proportion of staff that are trained to master's level, who are able to then support their junior colleagues when this arises. Sometimes it's not just bodies on the floor, but it's skills that are important. And we've been investing a lot of time in remote training of skills. But actually, one thing that was really interesting that you alluded to earlier was around checking. There's no point in training people unless we check that that care is actually happening on the floor. So we've invested quite a lot of time in looking at how do we check that care is being achieved, and how do we check that things are being done properly, and maintaining the high standards that we would expect to maintain. So it's kind of a whole feedback loop of training, but also checking and auditing that care has happened.
Ian, thank you. The one other thing I'd like to draw the group's attention to, and it's very pertinent for us at the minute, is we have seen shortages not only in PPE, but in hemofiltration circuits and in medications. And what I would say to all of you is you need to start thinking about that. I mean, we're at our peak now. We're expected to stay there for the next 4 weeks. And we have seen national shortages about these things. And I think if you can plan how you mitigate that, you should start doing that now. Now, I don't particularly have any of the answers, but certainly around, I think it's 70% of the patients that we've seen in intensive care require hemofiltration. And we are running very low in those stocks. We are having to think about how we sedate people, how we mix medications, which is a very unusual thing for us to do in the UK. We're having to think about how we use our paralysing agents, how we use our anaesthetic agents. We also have had to think very hard about what ventilators we're using. These are a finite commodity at the minute. We are reliant only on what we have within our hospital. There is a national supply. Our government talks a lot about a new supply of ventilators, but we haven't actually seen any. So again, you need to think about what machines you have at your capability. One of the innovative examples are that for our ECMO patients, because essentially the lungs that we're supporting with the ECMO machine, the gas exchange is very well maintained with that, is actually we've downscaled the ventilator that patient is on, and we've moved them to a very low-grade ventilator, thereby saving our high-end, high-tech spec ventilators for patients who are weaned off of ECMO, weaning off of sedation and heading towards a tracheostomy. I'm happy to take any questions about ECMO or our critical care or our education processes. And again, very happy to provide any of our education pathways and our protocols that we've been using to manage our patients. Thank you.
I completely agree with you, Ms. Lauren. Even we have a swine flu epidemic in 2008. As a nurse, as a critical care nurse, I have learned about ECMO procedure, and there are a lot of insights working as a critical care nurse. And ECMO is not a small procedure. We used to do post-ARDS patients like prone position and ECMO facilitation. These are really valid informations. Definitely, I'll ask you your help for the link for those procedures. Because time is running short, I'll go to next question to Miss Padma ma'am. Ma'am, like you have almost 35 years of exposure as a tutor and assistant professor, you're working and you're running in school. So, ma'am, as a students, what kind of pain points, like a students when they are working and when they are in student period, what kind of SOPs and training modules you have developed to deal with such kind of pandemics, not only COVID, any pandemic, how you deal? And do you have any simulation labs in your country and how you make modularized to use them? Any new technology, like now everywhere you speak artificial intelligence, there are a lot of activities are going for nurses training. However, in India, we wanted to keep bar to rise the bar with evidence-based practices and upgrading and updation of protocols, but still there are lacunae on hands-on training, and they're not much cope up with the simulation labs, not much support from the government. There are certain colleges, even they don't have simulation labs. And there is, theoretically they are very good, but when we took them into the board as leaders, we are facing a lot of challenges with lack of skills and lack of, theoretically they are good, but sounds good knowledge, but when they comes into practical, there are a lot of evidences, no stimulation on hands-on training. Simple IV cannula procedure also, they are not well versed to do. What kind of challenges and how you are handling your students, and can you give keynote for us, ma'am, Dr. Padma? Over to you.
Thank you. So it has, education itself has taken a big we are all facing these challenges where we have to give them hands-on training. We have had to switch all of them to simulation now, because our school especially, and most of the schools, have restricted the students from coming on campus. So all of the didactic content, we have switched that to online modules. So as is, I think globally, I think all the education institutions have done that. But there are a lot of simulation software that we are using both for the BSc nursing students, and also I educate the master's students, which are the nurse practitioner students. So we've been using virtual simulation that has been provided by companies such as Elsevier, that has virtual simulation modules that we are providing for the students in order to do the clinical hours, because our main focus was to place the students in clinical settings with a preceptor where they learn their hands-on experience, which they are not able to get anymore. So with the virtual simulation, fortunately, we have a lot of support, both from our educational institution as well as from a lot of the associations, nursing associations. There is American Association of College of Nursing. So, and we're getting a lot of support from National League of Nursing, from the American Nurses Academy, and a lot of webinars are coming up to educate the educators about taking it online, and that has been really, really supportive. And I think, to speak to all of the other people I think we are all also facing information overload, whether you are facing it as a nurse, whether you're facing it as an educator, or just as a common person. I think we're just inundated with so many resources. Like, I don't know what resources to tap into and what not. So I think streamlining those resources, and so as an educational institution, we have had several webinars, and we do a huddle, so to speak, every virtual huddle every week, in order to provide support to our faculty, and then also to our students. So virtual simulations are ongoing. It has been a challenge to move from a hands-on experience to virtual, but the students have adapted really well, and so have the faculty. Clinical hours, making up the clinical hours is a challenge, but for the students, but we are working closely with the companies that provide simulation experiences, and so far we have been successful. But as one of the speakers said, this is an ongoing, we don't know, it's an uncertain times. But I think as a group, globally, I think nursing is coming out really strong, with the amount of support we are providing each other. Just take this global webinar as an example. I think it's excellent that we are all providing this support to each other and sharing information. And so kudos to information technology and providing these platforms. I could not imagine 20 years ago what we would have done without this information, that we are even able to meet virtually. So that's how we are facing this situation as far as clinical experience is concerned. Thank you, Swati.
Thank you, ma'am. Very well explained. Now, I would like to ask Ms. Josephine, ma'am. As you said, you have designated COVID, non-COVID areas, and you have been, provided separate hostel. Are you provided separate hostel for them? Our nurses are merging with normal non-COVID patient area. Whoever taking those nurses in the same hostel, ma'am. I have a question, because there are a lot of logistic issues where the COVID nurses have to be separated, and they should be not mixed with other nurses, and they have to have separate rooms. and while handling COVID patients, they can't mix with other nurses. What are the challenges, ma'am? As we wanted to know, because a lot of nurses, these nurses are working in COVID, which I don't want to mingle with that nurse. Ma'am, please me let us not to club with those nurses, because nursing hostel we can't divide it every floor and everywhere. So these kind of challenges we are facing. Can you give keynote for all that, ma'am?
Yeah, very good question and very practical question, Swati. You see, first of all, choosing nurses for the COVID unit, you have to be very, very careful. What simple funda we have done is, we have called the entire critical nurses, ICU nurses, who are posted in various critical units, and we put just one question to them, that whether they are interested to work in COVID unit. First of all, we had a lot of training, so they are well informed about COVID-19 and the challenges. Now the question comes, your physical setup is ready. Now we need the manpower, that is the vital manpower, nursing manpower we require to function that area. So the good thing is that I think the core team and us could convince the nurses that there is nothing to be scared of as such, and people came forward willingly to work in the unit. So the team which we have prepared around 45 plus 15, around 60 nurses we prepared, theoretically, practically, with all the challenges, not many trainings done, and they willingly got posted in the area. Now coming to the residents, see, we have 5 hostels in this hospital. It's a big hospital with around 850 nurses. So most of them stay in the hostel, so there are many hostels. Now, there are married people and there are unmarried people. And the married people, some of them have very good accommodation back home. Some of them are living with their elderly parents. So we have given them a choice. During the time when they are posted in the COVID unit, if they are willing to stay, if they have a problem staying at home, they have elderly people, they have small children, and they have long way to travel. Hospital has provided beautiful accommodation, single room, with attached bath, with all the facilities, food served to their room, bathing facilities, everything given to them. So the good news is that majority of the nurses who are looking at these facilities, they stayed in the hospital premises, and those who have family commitments and they can manage at home and they have enough facilities, they went back to their own home. So the policy states that it is not so strict that they have to stay within the premises. Now, mixing with other nurses, the nurses who are posted in COVID unit are not posted elsewhere in the hospital. They are identified, selected, and trained and groomed to work in COVID area. So they work only 7 days, depends on which shift they are in, and they go for quarantine for 14 days. And during that period, if at all they are unwell or they need any medical attention, they are discontinued from that job, and immediately they are called to come to the hospital. They are taken care. And even then, if they don't wish to go back to their home, they are provided with accommodation, food, and all the comfort in the hospital. So there is no question of COVID nurses posted in COVID unit getting mixed with others. There is no question of people unwillingly working there, and there was no challenge at all in taking care of the accommodation. I think basically what I learned from this whole exercise is that we leaders have to come forward and make them understand the old practical aspect of taking care of this patient. And if you follow all the policies and protocol, like I heard a speaker telling about patient on ECMO, patient on ventilator, we had all such cases, and they beautifully managed adhering to all the precautions which are being taught to them. So I think that fear factor is slowly subsiding. More and more nurses are willingly coming forward and registering their names. If at all in future, more nurses are required, there is already 2 batches ready to work in that unit. That is the beauty of, I think, the whole program what we got implemented. Thank you, Swati. I hope you could hear me.
I completely agree with you, this keynote. Even our management, when I have this crisis situation, when soon after lockdown started in India as well as in Hyderabad, a lot of cases was notified, and we approached our management, tried to accommodate. People were not willing to go home, and they have elders at family and kids. So a lot of initiations we have taken, and we spoke to them continuously. We educate. and we have been provided separate, triple sharing rooms with deluxe facility, such kind of activities. We supported, and we told them we are there for you, and the management was provided the food and accommodation beautifully. They were enjoying nice music. As Clara ma'am said, we have provided all kind of facilities. They never feel like they are away from home. They management has well taken care. As a leader, when we go and approach, the approachment was very well taken, and they valid our points, and they have been given front, and they given all kind of facilities. Ma'am, I really thank you for this input. I would like to ask one question to Tanka ma'am. How can we establish effective staff safety protocols? How you are taking measures to monitor and surveillance supervision of the long-term adherence to the infection control practices? Not only this pandemic, when pandemic outbreak comes today, coronavirus, last time we had SARS, before Ebola, these are a lot of challenges as a nursing leaders. How we have to overcome these challenges? Over to you, ma'am.
Yes, Swati, thanks for that question. And I'm sure that particular question must be going through everyone sitting here. We have gone through Ebola, we have gone through SARS, MERS, all kind of things. But somewhere don't we forget that it happened. But Corona is playing a different game altogether with all of us. I hope I'm audible. Am I audible?
Yes, ma'am. Yeah.
So the way that I am experiencing this, I was in hospital when the SARS came, the MERS came, I was in hospital. But I don't recollect this kind of fear, this kind of what you call entire nation being in lockdown. This is the first time experience. We never had. We had, epidemics, and we have managed. And initially, a lot of data was also given that, regular influenza causes this much mortality, this one causes this much mortality. We have threatened nurses that, if you don't follow standard precaution, you will get hepatitis B, you will get HIV. But they were not that afraid. But suddenly, what's happening today? We know that in reality, what is the mortality rate in different countries? They have different mortality rate. It's not very high, but it is very high in susceptible, candidates. And we also know by now that if we take certain measures, we can reduce the mortality rate. The other thing that what I'm observing outside being a healthcare system is that there is also a need for clinical excellence in the areas where we are looking after very critical patients. Patients who are on ventilator, who might need drowning, ECMO, the advanced one. So when I look at India, so far, the mortality, I'm not talking about regular mortality, I'm talking about mortality of healthcare workers. So when I look at that, when you go zero down to which state, which district, which hospital, I wonder, did they have that clinical expertise to manage? I know that there is no standard guideline so far as to how to treat, but definitely if the critical care team is very good in managing ARDS and multi-organ failure, they should be able to do a better job. So what I'm learning from here is that one is, of course, infection prevention practices. Whatever that hype is created now, we all should be thinking today that what happens tomorrow? How do we capitalize from this momentum that is being created? There are two ways to look at it. One is to say we have this mountain of crisis in front of us. Let us get over this, then we will think. But I think as leaders, it is also important to start documenting. What are our learnings today? How are we going to capitalize this when this thick cloud, clears? Right now, we are all fighting because there is something urgent in front of us, and we have to do everything that is possible. I don't think that anyone who is on this panel today said anything which is not right. Everything is right. Starting from the physical safety to emotional safety, allowing the person to express the grief, allowing them to say that I am okay. So, and in all this, most important thing is obviously adherence to the infection prevention so that they don't get exposed. At the same time, ensuring that we are giving the best clinical care possible. to those patients who are coming. So we have stories where a 101-year is getting better, and we have stories where a 45 or a 35-year-old is also, we are losing them to this particular disease. So the medical fraternity definitely is, trying to collate all the data, put things together. So there will be new evidence that is coming up, since we have people from different parts of the world today. So today I have just read one recommendation which has been shared by one of the very senior critical care doctor that I have worked with. So I'm just sharing that with all of you. This is for you people to, implement and then see that whether did that make a difference. So while we are doing all this, there is a great opportunity to collect data and then tomorrow use it for the better future of tomorrow. So tomorrow, if something happens, at least we know how we manage the pandemic. And nursing as a fraternity across the world, I'm sure that a lot of nursing groups are working towards that. So in India also we have to get together, and I'm hoping that Association of Nurse Executives India will become an instrument in collating all this funding. So let me come back to what I wanted to share. What is being suggested is that if you have a Betadine nasal spray, I have not seen one yet. If you use Betadine nasal spray and use Betadine gargles, they are recommending this for staff who are going to work in the COVID areas, and they are saying that they are hoping that this will reduce the risk of the caregivers. Now, obviously, anything that is now being recommended, they have not been tested before, but common sense says that yes, maybe you can definitely keep that area more resistant to the virus. And we know when we get a normal sore throat, I manage that by doing Betadine gargles and warm saline gargles. So we know that there is some role in that. So I'm just leaving this with all of you. And in case you have any experience with that kind of a thing, please do share. I mean, we have people from UK and US, in case you have something like that, because this has come from outside India, not from India. That was one question. And Swati, your answer, I would say, is that whatever that we are achieving through this current momentum, we have to have a way to capture the good that has happened, convert them into sustainable practices once we are out of this crisis. That is my answer. Now, I asked one question, so the panelists can answer, so benefit everybody, if you have any experience of using Betadine. And my second question will be to Lorraine, because I came across a suggestion to keep the ICU nurses not to be going to the patient very, very frequently. They can bring the entire, syringe pumps where you put all your vasoactive drugs and everything, whatever that you are giving, bring it outside the ICU with longer extension, so that you can mix, you can change the rate without going to the bedside. And we know that in ICU, a lot of time the nurses are spending is actually playing with the IV and things like that. So I saw some photographs. I think it was done by, I'm not very sure which country, whether it is UK or US. It is actually practiced by one of the ICU centers. So I had these two questions to ask the panelists here, and also our own panelists in India, in case you have any such experience. It may be a good thing to share, because I don't think that Betadine will anyway harm, if not have great advantage, but definitely it will be of some protection. And if there are good things, why not try that? Because right now we don't know everything about corona. So it is like, okay, whatever best we can do for our healthcare workers, we must adopt. And I think that will only help. It won't harm. Thank you, Swati. I hope I answered your question, and then I asked two questions. Okay.
Yes, ma'am. Thank you, ma'am. It's really good. Miss Lorraine, can you pinch? And ma'am was asked, is there any studies or evidences has been proven that Betadine gargle, either Betadine nasal swab, will help you, the nurses, before treating COVID patients?
So, to answer it, can you hear me?
Yeah, Miss Loring, Miss Tankam ma'am asked you some practice like betadine gargle, either betadine nasal swab will help you before entering COVID patients. Any nurses in your practices are you practicing? Will you share with your experiences?
Okay, so we don't minimize contact with patients at all in the intensive care. We advocate people going into full PPE, spending 6 hours, probably no more, at the bedside and then taking a break. And that's how we kind of are as efficient as possible with our PPE. And I'm just looking at my colleagues. We have no experience at all of using betadine or any kind of spray with regards to preventative measures. And just while I've got you, I'm really sorry, but the UK team, we have a stand-up emergency bed meeting to attend, and it's been great listening to all the different experiences of colleagues, and we're going to have to sign off now, I'm afraid, but very happy to take any questions online and or by WhatsApp, and if you want any of our education programs or proning programs, protocols, please do just let us know. And thank you for your time today. It's been great. Thank you so much.
Thank you, Lorraine. We'll be in touch with you.
Lovely. Thank you.
Thank you. Yes, Suresh. Mr. Suresh. Do you have any experience?
I'd like to share my experience from UK point of view. Well, we have a very strong governance in terms of using drugs. So we'll have to rely on government resource and also scientific evidence. In UK, we're not allowed to do any trial on our own within the hospitals or any community settings. So that means we have to wait for Public Health England advice, and also there's a pharmaceutical guidelines working closely with NICE guidelines and Department of Health. So they will have to produce the guidelines, either it's for trial or outside the trial. So, but unfortunately, we are not having any trial at the moment in terms of using betadine. Yeah, thank you.
Okay, thank you, Suresh. As ma'am asked one more question, like when you are using inotropes, lot of inotropes we will use with the syringe pumps, like when patient is in ICU, you have a lot of vasopressors and dopamine, lot of syringe pumps. What is your experience? As ma'am requested to use that longitudinal tubes, either, you have three-way extensions with the pressure kits. Do you have any such kind of facilities you are experienced? How you are using?
Is that for me, Swati? Yeah.
Yeah. And Tankam ma'am asked you one question. For all the panel members, do you have any good practices like when we are using lots of vasopressors like dopamine, not many syringe pumps with ICU patients on ventilator? Do you have any good practices? As ma'am said, it is away from all syringe pumps will be out, and the nurse will not go frequently, to visit in the ICU, or you have any good equipment with good technology away from the patients where you bring outside and you are using any such kind of devices you have in your side?
That question would have been really suitable for Lorraine, really, because I'm out of practice from ICU perspective. So unfortunately, I couldn't answer that. So apologies.
Ma'am, any Indian SSS? Josephine ma'am, either Clara ma'am?
One point to make, Swati, for the ICU patients, as Tangam suggested, it's a very good suggestion, but we haven't started anything of that sort, using an extension and managing. But for the stable patients who are admitted in COVID unit, what we have done is we have told the nurses to do activities and not to go to the patient room frequently. Like we nurses have the habit of frequently going into the patient room, they work, they check vitals, then they come back, then they go for other assessment, reassessment. We have strictly told them the active, involve the patient in their care, self-care model, let them do how much they can, especially stable patients, do only things what they could not do in an organized fashion, so that your entry to the room is not frequent, and minimize contact with the patient. That is one step they have taken. Thank you.
Yes, ma'am.
That was a very wise questions that are asked by Tankam. Actually, we have no evidence to it, but however, for all the nurses who are taking care of COVID patients, we do give warm drinks and we also encourage betadine gargles before and after. We are yet to see the evidence, but those nurses who have had their gargles and nutritive drinks and nutritive supplements during the period have not yet been shown as but just sharing the experience. And in terms of limiting the connectivity, we have formed a module called the Connect, Organize, Visit, and Exit. So these are the 4 steps that we have taught them so that they connect with the patient by online, on WhatsApp or connectivity in one of the hospitals. They have connected the patient room and the nurse's station to the boardroom also. We could even see the monitors so that many doctors or referent doctors need not go in. So such facility has been tried, and we can probably be sharing it in length if anybody would require such information. But connect, organize, visit, and exit becomes the nursing care protocol. So they collect, assemble things, get in, complete, and then visit the patient, come out. And they will visit again until there is a need. So it is a mutual planning between the nurse and the patient. And if patient requires, they can connect with WhatsApp.
Yes. I completely agree with you, ma'am. Even our unit, we have instructed our nurses to do betadine gargles twice in a day, and they were doing even 3 times in their brushing. As Tankam ma'am said, like COVID patients, for stable patients, we have restricted number of visits to the patient. Only for vital signs, twice in a shift, like 6 hours, 2 times, and then a number of shifts we have been restricted even in our unit. All the nurses, as you given that suggestion for extension tube, we also dealt with our critical care consultants and the vendor management, ma'am. These vendors we have been approached. These questions, as a critical care nurse, which I worked in last 10 years, which I exposed into the ICU, I have this question also in my mind. If longitudinal tubes and away from the patients, a lot of restriction. If you make, a lot of exposure cannot be done by the nursing. Next question I would like to ask Jyoti Clara ma'am about nutritional status well-being about our nurses. Like how we will initially, the nurses, they are getting hostel food. How much we will provide for the high protein diet? Still they have challenges. They're not getting proper diet and they have lot of issues. So we consulted our dietitians to give good diet charts and specifically this COVID patients, whoever treated and whoever been working for long hours, like 6 hours also for them wearing that PP is not that so easy. They were so sophisticated and they feel that so tired and so fatigued. So kindly explain how you are coping with nutrition supplements and balancing their health status, and how you breaking the shifts within 6 hours, how you motivated to do the nurses and to encourage for them.
Actually, learning comes from experience. When we had the first hospital started receiving the COVID patient, we asked the staff nurses, and then the staff nurses told 6 hours will be difficult. We will try and do 12 hours, and then they started with 12 hours. But then we were not happy with it. And eventually, within 1 or 2 days, we come to realize they are understanding the exhaustion. So what we did was like we shifted the 6 hours duty, and then it could be extended to 8 hours depending on the flexibility. But within 6 hours, every 2 hours we prefer to give them a break. Now, how are we going to provide them a break? This was a great learning exploration for us because with the COVID test, we did a mock kind of a drill. How do we literally do the nutritive supplements taken by the nurses? So, what is the best kind of nutritive supplements? We cannot be, money comes from nowhere. We have to make whatever revenue we have within the hospital and whatever we can procure. So what we thought was we listed on certain staple foods, which is high nutritive foods like groundnuts, then we had jaggery and certain pulses, and then we had wheat and other kind of like paneer and some of them like yes they prefer non-vegetarian. So we thought nice chapati rolls and then a good chicky kind of for burfi that we made. So these are the things that are wrapped onto the foil and then they are placed for them. So what happens is every 2 hours, what do they do is they literally, I have a actually demo on that. They will just hold on to the tip of the mask. They will just pull it out and then they can insert the straw, have the nutritive drink, and then they also bite small bites they can have. So each time they take that small bite, they become more comfortable. But how do they do it? Because they should not infect themselves. At the same time, they have to follow the precautions of PPE policy. So we told them how to doff the second gloves, and then to use hand sanitizer, and then how we have to provide the buddy person who is there and support them as to how they have to hold and how they have to take. Now, all these happening, they become more comfortable. And not only that, after they have completed the shift before and after, we give them warm drinks. And they were taking care with special care. So when they go to the hostel again, we sometimes ask them the preference. Every day, egg is the most economic and the best whole nutritive food. So we advise them to take egg. Even some of the nurses who don't like eggs started taking eggs. And we also added milk and banana. These are some of the things we tried. We don't know how scientific they are. However, Tamil Nadu government has given a very good nutritive prescription for patients. So we have taken some ideas from that, like milk, and we advise this to them. Like we take milk and then we have to add a little bit of jaggery into it, and then we can add turmeric. So turmeric and then pepper. So you boil it well. So it becomes a condensed drink, which is sweet, but it also has pepper and turmeric, which is actually a proven good antioxidant. So they can take that. So these are some of the things. In one of the units, we tried kashayam. Kashayam is a very traditional type of, maybe it is called as special drink, like special tea or nutritive tea or whatever it is. So this different varieties. So one of our dietary person innovated 6 varieties of kashayam. And not only those nurses, we all take that also. So at 10 o'clock, there will be a message across for SLT, everyone. Kashayam is ready, please come. I do also take that. Sometimes it will be a little sweet, some days it will be salty, some days it will be so different things. So we could taste that, but we could see it is soothing our throat. But I don't have evidence of any of this. But there are literature in India, the traditional literatures prove that these are some of the ingredients that are very good for health. So this is how we take care of their health. We monitor their weight. We also brought a quality indicator, which is very nice. I thank God for giving us the insight to discuss about the quality indicator. So the quality indicator, when we say we measure the staff nurses, I could show you the quality indicator here. So this is the one we had prepared. Maybe it will not be very clear. So it has got certain indicators like accidental exposure, we monitor that. Then wear and tear, while doffing it is there happening, daily screening of the staff, exposure to blood and body fluid exposures, needle stick injury while taking care of COVID patients because it is additional caution that we have to take there. Hydrogenic injuries because of masks and all the PPE. See, 2 things in PPE very important. What is the type of PPE they use and what is the material it is made of. We innovate lot of learning in it. When we open the PPE, sometimes we wear it becomes very hot. And we found we have rejected few PPEs because it was not at all very comfortable for our staff because it further gave more discomfort and hydrogenic injuries for the staff. So these were the things. Weight loss among nurses, urinary tract infection among nurses, GI disturbances, stress-induced health issues, and some of the prophylaxis, whether are we giving them regularly, like vitamins, vitamins, zinc supplements, and then prophylaxis, whatever prophylaxis is prescribed according to the state, and we couldn't follow. Number of nurses affected with COVID-19, number who have become positive, and number of nurses who have worked in suspect unit, COVID positive unit, the number of hours of exposure, number of shifts of exposure, number of patients in exposure, and the time that is average time given for to rest and relax. So these are the quality indicators we are monitoring, which as a dashboard, when I get it, it's very comfortable for me to even understand, yes, the nurses are safe.
I completely agree with you, ma'am. Even when I childhood, my grandmother used to tell me this Ayurvedic drink which you suggested. Really, I feel still remember those days. I completely agree with you, ma'am. Now, finally, I would like to ask all panel members, as a leader, what is our major contribution to involve our nurses, little RNs, on policy making during such pandemics happens, to involve whether decision making on policies? Do you play the major role? Everyone, 30 seconds, please, as much as fast you please answer to my question, ma'am. Are you involving our little audience when we are taking policy decision taking?
Yes. Yes.
Yes.
Yes.
I'll say in 30 seconds,
Yes.
pandemic, no pandemic. If you make policies without having them on board, it is going to fail because they are the ones who are going to deliver what you are writing. So that has been my policy even before, and it is even more stronger now. So totally, yes. Little R&D should be on the big table. Yeah.
Just one last thing. I wouldn't even say that it's a little RN. So they are the key part. I wouldn't even use that word. The thing is, two things. Yeah, it's about policies and procedure. Who has the time to read 30 pages of policies? No one has. So let's keep it simple. It's called business continuity plan. That's very key. Yeah, I mean to say that business means our business to take care of our patients and take care of ourselves. So that means having one business plan, continuity plan for a hospital or organization, then have a one localized plan. For that localized plan, involve all the key clinicians, not only nurses, not only AHPs, doctors, everyone. Maybe include your healthcare support workers, include your housekeepers. Yeah, so that's a part of the key learning for us, really. So thank you. Yeah.
So I like to say, let us stand together and stand strong during this uncertain period. And here we have 200th anniversary of Florence Nightingale. I'm sure this year is going to prove really beneficial for everybody, all stakeholders, and all our RNs, and all of us together as a team are going to do a great job. And hats off to all of you. Congratulations again. Thank you, Swati.
Yes, I would only say that COVID has selected the best year to appear, the year 2020, year of nurses and midwives. And I'm sure all the nurses are the one who is going to save the nation, save every family and every patient. I really appreciate the guts. I am not a teacher, they are my teacher. So this morning also connected with my nurses across, those who are taking care of COVID patients. Jessica is my CNO from Mumbai and Harita from Hyderabad and other CNOs. What I told those nurses were, you are my teacher, because my brain has not seen it in reality. My hand has not performed it. I only know by knowledge. But you know by practice and you know by attitude because your experience is there. They are our teachers. That's what I would like to say.
Okay, any more questions?
My little RNs are doing a great job, and in the COVID unit, I have male as well as female students working so sincerely. I really salute them, appreciate them. Their efforts are always implement the COVID protocol for caring COVID patients. I salute them. Pray to God that time will pass and we will do a great job. Thanks.
Ma'am, I would like to thank hospital management to giving me an opportunity as a moderator and all the panelists across the globe. I was really blessed to have all the panels and gathered here, and they contributed on this webinar. Many facts today, which in fact their experiences, and it is an eye opener for me. And this session is very informative, and you have shared your valuable experiences and your thoughts with us. Definitely, ma'am, we will follow your path, what you have been given today, ideas and your valuable informations, experience. Definitely, it has become really for us as nurses. Many of nurses today, they were facing this challenge, how to involve in the management and how to handle the situation. It helps a lot. As a leaders, we are the most key members to play a major role. Not over the handle. Once this lockdown is open, my worry is more and more patients go high, and the fatal rate, maybe as Tanka ma'am said, the mortality rate is very less, but fatal suspicious high, highly old age people as youngsters. And this is one of the challenge, going to be collective fight. No single individual can win this battle. We have to work as a team, and as a leaders we need to be strong to the showcase our team that we are there with you and we will help you. That kind of bonding we should develop, and the experiences are life changing experience. And this COVID has taught us many lessons. Every day there is a new learning for me. I've opened WhatsApp, every day there is a new article, new protocol, and new guidelines has been given. So I really congratulate all the RNs who have been working with these COVID patients. And I stop, no, if you stop educate our little ones, they feel that if you don't be with them, they are, feel that we are not taking care of them. So we have to involve our little RNs and we have to be support for them. And as a mentor, as a leader, we have to take their decisions and we have to ask their doubts and their ideas to share with us what kind of challenges they are facing day in, day out. Every day, it is everyday lesson for us, and we have to be keep motivating our RNs, keep on regular counseling and supervisors to be monitor. We have to take, as Jyoti ma'am said, quality dashboard and how the PPS are using, what kind of challenges they are facing day in, day out, and they have any kind of situations where they cannot use these kind of PPs. We should give a empowerment to the nurses to create such kind of environment. Once again, I thank all the participants and panelists to join for this program and make it grand success. Ma'am, please tell little suggestion from all your panelists. Like as Jyoti ma'am said, you have sent that quality dashboard to us. Ma'am, Padma ma'am, you said some simulations, how you are utilizing in your US or UK. Suresh, you also can share the links like how counseling and psychosocial therapies will help us. So it is really very good benchmarks to prove in us, and it's a good evidence-based practice where we will practice in India. Thank you all. Be safe.
Yes, I would like to mention that Association of Nurse Executive India is a very powerful association with all nursing leaders across India, and some of the international nursing leaders are also with us. Ms. Kamkam is the president, I am the vice president. So I think this particular dashboard, it has its own merit, and I think it's worth circulating through Andy. However, it is made by Clinical Global Group and Continental, but I would like to dedicate to all nurses, and probably through Annie we will be soon circulating. Ms. Kamkam will be taking it up and we will work on it, and then we will circulate it.
I want to add one thing. And I think we have to collect data. Nursing research is really important at this time. I think the more informed we are, that empowers us as nurses. So, let's all collect data and collaborate in research.
Fantastic.
Thank you.
Ms. Kamkam, please give your agreement here.
Yes, ma'am.
It's mute. It's a mute.
Your video is mute.
Sorry, I'm sorry about that. I already mentioned that, let us not get over this pandemic without having learned enough, researched enough. And we should come out with good evidence, to say that in going forward, this is what can work. And I think while the doctors are busy, they're already doing their research bit. Nurses should not let go of this opportunity. And Dr. Padma, let's not stop connecting once the webinar is over. We can write to each other, we can find out. And as Jyoti mentioned, Annie is a body with lot of top nurse leaders there. So the three people who are sitting here, Jyoti, me, and Josephine, we all belong to the executive committee of Annie. So you can see that anywhere when you bring 5-6 leaders, Annie will be definitely represented. So we should, because this had been my complaint even when I was in Fortis. My always complaint was that all the research, it is purely academic. We cannot use them. So let's make some useful, research, and for that, data is very important, and we should have a little bit of foresight to understand what should be the data collection, so that the data is collected well, so that when you start to study, you get the desired outcome that you can use it in future also. Because otherwise, sometimes too much data is okay, but if you don't have relevant data, then we are in for trouble. So I am sure that Suresh, Dr. Padma, Lorraine, who stepped out, I think if we come together, at least we have covered 3 large, countries in the world. So I think you can have more connects, and then we can together do a multi-center, study. It could be as simple as doing this. Betadine. It's a self. I'm sure, Suresh, that in UK also you can do a gargle yourself. You don't have to ask anyone. So a nurse can obviously do a gargle. So at least if we say that this is the protocol we followed, and then over a period of time we will know that how many of those nurses who are doing the gargles and not doing, maybe there are other variants there, but still we will have a kind of some kind of reassurance to say maybe this practice is good. So maybe something like that. I'm sure that between so many leaders there would be a lot of things, and the dashboard, definitely, thanks Jyoti, we can look at it, we can make it into a standardized template where everybody can use that, and then probably even from that also we will get some data to learn from. And we just have to make sure there are other influential factors are captured. Then obviously it makes a lot of sense, because I do train nurse leaders on interpreting data, and how to make two numbers talk to each other. I think that is a need of the hour for every leader, because any one number by itself is not good. I'm a critical care nurse, by the way. So when my nurses will say the urine output is 40 ml, I say, no, tell me more things. That 40 ml does not make any sense, So I am brought up like that. So even in administration, I think we just need to be more practical, relevant. So Annie is all for that. So let's connect. And Sunita, I know that we have not interacted too much. You are welcome to join Annie, and we can all work together. I mean, nobody's made outside Annie, they're all part of Annie. And even our Indian nurses who are outside, you all are welcome to join Annie and be part of that, So we can always do that. Right now, we have a war to win. So let's go out and win the war, right?
It's true.
And prayers to all of you, all for you, and all the people out there. Every day morning when I get up, I am in grief. That's the reality. But things like this, when we start get together, talk, the hope is rekindled. I'm not in the hospital front, and I am at the back. I'm trying to do whatever that I can do, but I can only tell one thing. I totally relate to Suresh that the grief one feels, whether you are there a friend or you are behind. I think behind is more painful, because you are not actually fighting. You are right at the back, just thinking about it, and worried what is going to happen. So we have to say, I'm not okay. And we just have to be together. This is very important. This is not a competition to show who is better.
Yeah.
Because we are as strong as the weakest link. So let us not become that link. My request to all of you.
Yeah.
Ma'am,
Thank you,
the
ma'am.
captain of the
Thank
ship
you,
is
Suresh.
always there. The captain
We
is
are-
always there on the ship.
We are all from
Always.
desert hospitals. There is so much outside where we are not reaching.
Yes.
So I'm sorry about that.
I think just one last point. I think from Indian perspective, still you haven't reached a certain level yet. I think UK is suffering, US is suffering already. That means we are reaching near the peak. So I'm just praying that India shouldn't reach the peak. It just flatten as quickly as possible because of the population and also the socio-economic status, and people's living and lifestyle choices are so different. So I'm just praying that India should get away with it and actually prevent all these things happening in the future. But it's good to link up with all of you, really. Thank you so much. Just one last formula I just want to say is simple as 1C equals 3C. I just want you to, it's like a catchphrase, really. 1C equals 3C. 1C means it's a COVID, or you can say crisis, but 3C is very important. It's coordination, collaboration, and communication. If we get this right, we can contain this pandemic, and also we can prevent this happening again, either second phase or even in the future pandemic. That's very, very key. But thanks for that. Be available and be adaptable. Thank you.
Thank you very much, sir.
Thank you.
Thank you.
Well said.
Anyone, anything to share, ma'am?
I just want to say, together we can, together we will fight it, and there's nothing impossible. We as leaders
We
are
have
like the
to do
captain of
a
the ship.
virtual high five, everyone. We have
High
to do
five.
a high five.
High
Yes,
five.
we
Yes.
are going to make it.
Yes,
We are
we're
going
going to
to
make
make
it.
it. And unfortunately, today WHO head has just announced this COVID-19 is not going anywhere. It is going to be with us for a very, very long time. I was just reading the article. So that hope from WHO is now taken off, and very rightly Suresh has told, India has not yet seen, and that's my worry, because when you are watching what else is happening everywhere else, yes, India has been blessed by God, because with all the constraints that we have, the mortality rate, the morbidity rates, etc., in normal time, very comparable to international ones. So I always used to say when I was a nursing head to my CEO that you are not understanding that how much of God's hands is on us, with all of us, playing around with all kinds of protocols. So we know that in peacetime, and now people are more aligned to the protocols because everybody is afraid, because they are afraid for life. So people are, kind of aligned, but there is a nature to this corona which behaves in a certain manner in community and in healthcare worker, and we have seen that happen elsewhere. And India should not get into that, because we just cannot manage. We just cannot manage because we are already having a lot of problems. So we just have to pray together that we do not get into that stage. And yes, Suresh, your well-wishes and prayers are all there, because you all belong to this country and you mean well. But I think we also feel the same for all the other countries as well, because here we all are connected. If one country does better, other one does not do, we are again heading for doom, because our economy is totally shut down. We can't survive like this for a very long time. And I don't think that any one of us have ever seen famine or anything like that in our life. We have seen photos, and we are dreadful when we see those photos, right? So God help us, and we have to pray for the entire world and India in particular, that we don't go to that stage. Then none of our hospitals will be safe anymore. Right now, maybe you all are doing a fantastic job and trying to contain, keep the nurses happy, but once the normal English says, once the hell break loose, then there is nothing that can be done. So we just have to make sure that we never ever get there. So all the participants who are here, I can please follow what you have been trained. Don't do shortcuts, and speak up in case you have a problem. And let the leaders be willing to listen. Never ever suppress anybody from talking. Don't tell them, don't talk about this. There are some very very hurtful videos that come out where the clinician is shouting at the nurse, you shut up, otherwise I will fix you. Those things are also, India is a very big country. There are so many stories. There are great stories, positive stories, and there are as many negative stories as well, and we should know that we belong to the same country. So we have to ensure that they are also getting better and more compliant to what the directions have been. So we need to be cognizant about the fact, otherwise all our webinars, all these things will not help us. So we need to reach out and help others.
Swati, one last word from my end. Thank you for organizing such a wonderful interaction between all the leaders. I feel it an honor and privilege to be among all of you. It was wonderful hearing and listening to you. And I would like to thank India Operation Division, PPL, and all the global hospitals and continental hospitals. Without their support, I wouldn't have been possible for me to sit here and discuss. Also, I would like to thank the CEOs, the unit heads of each unit, for supporting the chief nursing officers and all the nurses for being pro-nursing. I think it is a great blessing at this point of time, and I'll fail in my duty if I don't do that thanks. So I thank each and every one of the chief executive officers and all the unit heads of all the hospitals. So thank you all, and thank you, Annie, for your presence here, because I was very delighted to see that Annie has come in the middle of this discussion.
With this, I thank everyone, every panelist, whoever participated and out of their busy schedule. I'm happy to see all. A special thanks to management. Last not but least message from my side: be safe, stay safe, be healthy. Goodbye. Thank you for all.
Thank you.
Great job, Swati. Great job.
Thank you,
Thank
Swati.
you.
Bye.
Thank you.
Thanks.
Thank you. Bye.